Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with bilateral blocked ears. It was predominantly dead skin, so keratin plugs as opposed to earwax. And I'm just commencing with this there right ear first. Now, this patient previously attended, I think 9 months or so ago, and on that occasion in the left ear, the patient had an ulceration of the floor of the ear canal, and some of the underlying bone in the osseous portion of the ear canal was therefore exposed. There was no active infection, however, so there was no discharge. There was a bit of inflammation with the adjacent skin. So we referred the patient to their GP to receive some topical antibiotics, and after the course of that I invited the patient back just to visualize the ear, just to check progress, because if the ulceration was still present, we would then refer the patient to ENT to rule out it's something a bit more sinister, maybe a canal cholesteatoma or possible benign osteonecrosis. Fortunately, the skin rehealed, and there was no problems. There's no symptoms exhibited by the patient, no pain or any itchiness or irritation in that region. But today they actually had an ulceration of this their right ear, which will become visible right at the end of the procedure. So this patient's entrance of the ear was very narrow and very bendy. So gaining access, we had to stretch the ear open with the endoscope, as you can see. And because we're using the endoscope to stretch the ear open, any wax that's near the entrance is going to be close up. It's one of the things that often people ask, why is the wax so close up? And it's just because the wax, or the dead skin in this case, is right near the entrance, and we're having to dilate the entrance of the ear using the endoscope. Therefore, it's going to be close up. So with endoscopes, the main benefit of an endoscope is the wide field of view. So when you enter the ear, you can see a wide panoramic view, and you can get various degrees of field of view. So the greater field of view results in lesser magnification, and the greater the magnification, the less field of view. So when we developed our endoscope for earwax removal, some of the endoscopes that I kind of trialed beforehand, the field of view was extremely wide, which therefore meant the eardrum was more in the distance. So when you're performing procedures deeper in the ear, it meant that you had to insert the endoscope deeper into the ear, into the bony section of the ear canal, which is really sensitive. And for me, that wasn't ideal, because you don't want you don't really want to push your endoscope too deep into the ear, because it can also then restrict your freedom of movement with the instrument in the opposite hand. So when we developed the iClearScope endoscope, I sacrificed a bit of the field of view to gain more magnification of the eardrum. So when we're working deep in the ear, I'm not having to insert the endoscope too deep, because obviously removing wax deep in the ear is more problematic than removing wax at the entrance. Now, with some endoscopes, so this endoscope, the diameter is 2.7, and you can get various diameters. So with some endoscopes that have a 4mm diameter, obviously it's almost double the size in the ear. But with those types of endoscopes, you get an extremely wide field of view, which is kind of sometimes good for if you're examining the ear, because you can then, when you're inserting the endoscope deeper to visualize the eardrum, you can have the endoscope in the center of the ear canal. But when you're performing earwax removal, you don't want the endoscope in the center of the ear canal, because that's going to obstruct the instrument when you put it in. So when we're performing procedures, the endoscope, for me, when I hold it, it's normally the bottom left of the ear canal in the right ear, and the bottom right of the ear canal in the left ear. So there's always some trade-offs there. But I'm very happy with the trade-off that we've made with the endoscope that we've developed. So this is a bit of granulation tissue, as you can see, just below the suction probe. And just above that, there's a bit of keratin here, and I want to remove that. And I uploaded a video just a couple of days ago, and I'm going to get the video number. I'm just looking on my other device to bring that up. And it was very similar, actually. So there was a bit of skin on the side of the ear canal. When I removed that, there was a huge void, erosion in the posterior canal wall due to a canal cholesteatoma, and basically the whole mastoid bone was kind of eroded. So it's video number 1549, so you can visit that on my YouTube channel. So I'll just repeat the number.
Hi everyone,
I was just playing it by accident. It is video 1549, and I've named it my most complex procedure, canal cholesteatoma, automastoidectomy, which basically means an erosion of the mastoid bone, which is the bone on the left of the ear canal, false fundus and glue ear. So when you see stuff like this, it's really important you kind of remove the outer layer of skin that's hiding and concealing what's behind, because we can see there now there's an ulceration, there's a bit of underlying bone exposed. So there's no discharge, although there is some inflammatory tissue around the edge. So again, they referred the patient to the GP, and we're going to get this patient back just to examine the ear. And if it's still exposed, I'm then going to refer the patient to ENT. So it's very possible that's a very early stage of a canal cholesteatoma. And so fingers crossed that can be treated, and the ulceration can be treated by the GP. If not, that will need onwards referral. So we have sent the letter to the doctor. So we're just moving on to their left ear. And again, the entrance is quite narrow, bendy. And I'm just pulling out some skin here. There's a few hairs there. And because we put some oil in, the oil coats the hairs. And we do try and dry those hairs, remove some oil from there so it doesn't smear against the lens of the endoscope, but sometimes it's unavoidable. And you can see there's a few more hairs deeper in the ear, so this is more matted. I'm just pulling out some skin, and I'm going to go in with the endoscope. We're going to stretch it. So I'm actually positioning the endoscope to the bottom right of the ear canal there, so it then allows me to insert the instrument. Again, just a few hairs at the floor of the ear canal, so just be careful here because it was blurring the lens slightly. I'm just going to go out, wipe the lens, back in again, stretching the ear open. I'm just going to go to the right at the back of the ear canal and trying to peel some of this skin away. But you'll see here the left ear is completely healed. There's a lining of skin, so the epithelial skin. Again, this skin is quite adhered to the floor of the ear canal. I'm kind of trying to drag it and lift it up. So I think I'm going to use the ear hook again. And I've just noticed I'm using the old ear hook. I think during the procedure, my toolkit had run out of my normal one, my new right-angled ear hook. So because there was quite an opening there, so I just carried on with this ear hook because I didn't really have to glide in between a tight spot. But I think because it's a bit more blunt, it was a bit more difficult to penetrate, but it was fine. We managed to work with that. So I'm just going back to the suction. I'm going to lift up and away. And you can just see how dry this section is and how adhered it is. So this is in between the first and second bend. And that's where all these hairs are. I was just going to wriggle it through the tight entrance. So that's quite a significant piece. Yeah, I'm probably going to use the ear hook again in a moment. So I'm just trying to lift this off the floor. So this skin, it's still adhered to the earwax, to the canal wall, sorry. So just lifting it up and away. It's quite dry, crusted, adhesive skin. And it's going to come out in a ribbon here. I'm really tugging away at it. I'm really pulling through. So yeah, I could have potentially reached out for the forceps, but by the time I reached out for the forceps, take it out of its packaging, put it in, I would have got that out anyway. So we just continued with the suction. So somewhat mobilized it from the floor. I'm just looking for a good suction grip, and I just think I found it there. But this, you'll notice in a moment, once we've got this wax out, the The remaining ear canal is quite wide. It's just the entrance that's narrowed. So this wax is collected in the wider part of the ear. Therefore, when I'm bringing it through, it's a real tight squeeze. And so I'm just going to go back to the hook, just moving some loose wax. There's quite a big space there, so we can insert this beyond and behind, hopefully. I'm slowly just rolling it forwards. Now I'm going to get fully behind it. And we're going to leverage this out. Or it's just dissected through. And we're going to go again with the hook. So there's just a gap there, so I can get in behind. Drag this out. So it came out a good solid piece. And we're going to just some residual, really dry, oxidized skin that we're going to remove. And you can see the ear canal is quite wide past the second bend. Kind of protrudes, balloons out. And that's where the wax is gathering. So deeper in the ear canal is more of a circle. In fact, I would say the width is greater than the height. But normally our ear canals, the height is greater than the width. And just that midsection there, so there is a bit of skin there. So I did peel that away because I just want to make sure there's nothing lurking underneath. This is when you perform earwax, it's really important that you examine, even if the ear looks kind of healthy, just like the other case that I treated the other week, 1549, although the patient had multiple pathologies, but they just seen some innocent looking skin on the posterior canal wall, and upon a removal, it's one of the largest erosions I've seen of an ear canal, and there was diseased bone there, discharge, dead skin, and we actually removed some dead bone from the ear canal. I used the ear pick there, so give that a watch. It's a really interesting case. So I'm just really tugging away at this. I can feel it loosening, so we're nearly there. I'm just going to bring this out the ear. I'm just having to manoeuvre it around the curvature of the ear canal, so it's quite a distinct bend there. So there's just some skin on the back part of the ear canal, just past the first bend. So that's on the right, the first bend, with the hairs protruding outwards. And just going to go back in, peel some skin off the roof of the ear canal. And we're using the fine end suction probe here, so it really helps to minimize any clarinetting. So if anyone new to the channel, when you suction dead skin, sometimes it can clarinet. And clarinetting is when the skin is just violently flapping at the tip of the suction probe, and it emits a very loud, high-frequency squeal. So I'm just having a real good nosy around here. So there's a bit at the front of the ear canal, so I just want to remove this. Because I know this patient's had an ulceration before, and because they've got one in the right ear, I just want to make sure nothing's hiding from it. Just at the floor. So at this stage, the endoscope's not actually in the ear, it's just on the outside, and so I'm having to hold it, and it's not being supported, it's not resting against the canal wall like it is when I place it in the ear. So I'm just going to keep that left hand steady as well, which can be tricky. So I've just got some crusted skin there. So I'm content with the, I think I do still remove some of the entrance, but this is on the cartilage portion, so normally a canal cholecystoma forms on the bony part of the ear canal, which is the inner 2/3, but we're just going to peel this away anyway. With skin, it's really reflective, so when you shine the endoscope towards it, it can reflect. So we can reduce the exposure, reduce the brightness, but it's not affecting me in the procedure, so I'm just carrying on. So I just got that skin there, and it's just a little bit at the floor there where it looks innocent enough, but I think it was, the ulceration was a bit deeper last time, so I'm just peeling it away. And I think we did get a bit of clarinetting, so we're going to stop here, but I'm happy with that. And I think you can see there's a bit of an erosion at the floor of the ear canal, but it's fully healed. There's no underlying exposed bone, there's no ulceration, so I'm happy with that. So I'll just let that skin flap back down again because it was clarinetting. That's the patient's eardrum. Well, I'm glad you enjoyed. I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.